Okay. Hello and a wonderful good afternoon with another very special edition of FotoFinder Academy.
Yes, today is a very, very special edition. We never had such an edition, let's say, about this topic. It's a unique, very new discovery
Catherine,
topic.
it's not only unique because of the topic, it's unique because of the couple that we invited, right?
Yes, yeah, wonderful couple. And yes, it's wonderful to have you here, everybody who is joining us. The hearts are already flying up, I see, before we started even. It must be because of our speakers.
But guys, let us maybe start. Why FotoFinder and DermLite have to invite you to educate yourself. People, recently, I was just telling Catherine, we had an event, and the topic was AI, artificial intelligence. And in that very topic, I had a DL5 with me on stage. And I told the audience that it was meant and it was the destiny for us to embrace DermLite, because the latest study we did is that the best artificial intelligence efficiency we can only reach if we have the human and the artificial intelligence in combination. So it's about the human and AI.
Yes.
It's about DermLite and FotoFinder.
Yes, yes, absolutely. And also if you bring us together in one word, I would say it is discoveries.
Yes.
And if you see FotoFinder side, we're working on the super high magnification dermoscopy. And today's topic is the DermLite topic. It's UV dermoscopy. And this is really a new vision.
And we invited very special experts and friends.
And
Catherine,
before we bring them in, just one thing, that today we have a very special promotion on DermLites. And you can benefit to be part of the Academy with a very great discount of 10% in the FotoFinder and the DermLite webshop.
We will tell more about that in the break. But where do we go? Do we go to Ankara or to Santiago de Chile?
I think we go to Turkey first.
Beautiful Ankara. And we welcome
beautiful Nisa, Akay. Hello.
Good to see you.
Good to see you.
Thank you for the invitation. Thank you, especially for this topic, because I also learned a lot while preparing this presentation.
It's a very new topic also. You don't have slides from 10 years yet, right?
Yeah. Actually, I was capturing a lot of photos all the time with UV dermatoscopy. But while preparing this presentation, it was so useful to me and I learned a lot. And thank you again for giving this topic to me.
No, it's
It's
a
an
great
honor
pleasure.
for us.
Let's go from Ankara in the heart of Turkey to beautiful Santiago de Chile with, I suppose, 8 hours time difference between the two cities. Cristian Navarrete. Cristian, welcome to Academy.
How are you? How are you, my friends? How are you, Moha? How are you, Nisa? How are everyone?
Lovely to see you. Lovely to see you, Cristian. How are you?
Good. Very excited to be here. I think this is my first time in this academy, and we're going to cover this beautiful new topic, which is UV dermoscopy, right?
True, true.
Yes,
Really
yeah.
excited. We are really
Yeah.
excited. And guys, you have to know, I mean, looking at the entire history of DermLite, I mean, there were several, let's say, incredible breakthroughs, revolutionary inventions. For me, still, the fact that DermLite managed to design a dermoscope that is integrated into our body with DL2. The DL200 is kind of it's more than a dermoscope, I would say. It becomes part of your body when you have it in your hand, and I love that. Okay, I'm a forever a DL2 fan, but the DL5 kind of changed the concept by empowering further your eye in terms of the depth with the UV, and that's why we thought we dedicate time to it.
Yes, absolutely. No, a handheld dermatoscope has so many possibilities, right, of visualizing lesions.
And that's why we are so excited. We are so excited, and I believe we will start with our dear friend, Cristian, because he has prepared a quite exciting presentation for you, everybody. Let us see, Cristian.
You can see my screen. Everything's okay, right?
We see your screen, man. You are fast.
Okay. I wanted to put this photo because Nisa, we look great here, right? It's
Yeah.
weird, this nice photo shoot of both of us. So thank you again for the invitation. And let's discuss about UV. I just wanted to start with what Moha was saying, right? Like the evolution of the modern dermoscopy. And Nisa, we've been around a couple of years now, so we've been living this whole evolution, right? And for most of you who are at home, everything started with the pocket dermatoscope, which was non-polarized light. You needed an immersion fluid. That was the first pocket dermatoscope, which I think made this revolution of dermoscopy because it was easier. But as Moha was saying, the first polarized dermatoscope, which for the first time, you didn't need like the immersion fluid. There were new structures appearing with polarized light. That was another big revolution, and this was all made by DermLite. And then, of course, in 2023, it was this, again, new dermatoscope with UV light. What do you think, Nisa? We've been through all this,
Yeah.
right?
Exactly, my dear. And every time it continues developing new ones, and I'm really very excited with the technology, with the marketing, and waiting for the new devices coming.
With new light modes, maybe new filters, who knows, right?
Yeah.
Or maybe super high magnification is something that's coming
Yeah.
like next time, right? So again, when we talk about UV dermatoscope, I think there are 4 different specific modes that you need to understand at home. And in reality, you have the real UV, when you have this light mode into the UV spectrum. And then you have the sub UV, which is like more than 400, 405, around that. So it's not really UV, it's sub UV. And you can have 2 modes for each of them. You can have a reflectance mode, or you can have a fluorescence mode. And I have 2 examples here because commercially available, we only have, to the best of my knowledge, maybe there are some yet, but like the sub UV reflectance dermatoscope, which I think Nisa will show us some examples also. And you have the UV induced fluorescence dermatoscope, which is the one that the DL5 has. So whenever you're seeing blue kind of spectrum images, we're talking about UV fluorescence. And when you're seeing these gray scales images, we're talking about reflectance UV. So this is something you're going to start seeing on the papers, on the books, on the presentations. So just be aware that when you hear UVFD or fluorescence, we're talking about the images from DL5. And when you're seeing these black and white images, is reflectance mode. Nisa, anything you want to add here?
Yeah, that's great. That's great.
So this is a very busy slide, but I think this is very important to understand everything about UV-induced fluorescence dermoscopy. So the first thing you need to understand is that the UV light has a narrow band, a short narrow band. So you'll find that this blue spectrum has only a shallow penetration. It won't go too deep to the collagen, to the deeper structures. It will mostly get images from the top layer of the skin. You need to know that UV light is not visible by the human eye. And the last thing you need to know is that some chromophores on the skin will release photons when they're excited with the UV light. Not everything, only specific structures, like for example, keratin will get excited with the UV light and you will get back some fluorescence. And this fluorescence is what you see with your eye. You can't see the UV light, you see the fluorescence induced by the UV light. And that's why this is the name, right? So remember, the visible light that you see with your scope is getting from the fluorochromes that are emitted by these molecules or chromophores that are excited by the UV light. And this shift from something that is not visible to something that is in the visible spectrum is called the Stokes shift. You're gonna see this term around. That's why I'm putting this very, very busy slide. And again, these photons that are emitted because of the Stokes shift can get some fluorescence. And another important thing is that melanin is made to absorb UV light, right? So anything that has melanin will most of the time be dark because it's absorbing everything and nothing is bouncing back to your eye, right? So that's why most of the melanomas, and that's why we use this UV also for the margins, is because you get this dark area in areas with melanin. Nisa, I think this is important, right? Do you agree?
Yeah, this is very important, Cristian, because there's some little differences between fluorescent dermatoscopy and reflectance dermatoscopy from this point of view.
And this is again to make you a refresh of how does the UV light works. So again, this diode from the dermatoscope is emitting UV light. UV light here is filtered by this here. So UV light is not getting to your eyes. This is important. It's filtered. So whenever there is a shift, imagine here, for example, from the UV spectrum to the visible light, you're going to get these excited fluorochromes that are into the visible spectrum that will be seen by your eye here because it's not anymore in the blue and the UV spectrum, and you can see this towards your eye. That's it. That's the only thing you need to know on how UV dermoscopy works. So remember, Stokes shift is the technical word for these excited chromophores emitting fluorescence, visible light structures. So in summary, remember this, the UV light has shallow penetrations because it has a very short nanometer wavelength. The fluorescence comes for this reason from the superficial structures, and that melanin absorbs everything, so it's black. That's it. That's the only thing you need to know for UV fluorescence dermoscopy. And I'm going to see some examples here. I'm going to show you some examples. With Nisa, we're going to start discussing some of these cases, and I hope you can learn. Nisa, can we see questions, or if someone wants to ask something, can we see that, or we are not available to?
We can see the questions on the right panel.
Okay, beautiful. So anyone's asking any question? No. Okay, let's
I
go.
will tell you.
Okay. So what I was telling you, what about melanoma and UVFD? So I use this every day. I do most surgery. I do slow Mohs for melanoma. And now I can survive without my UV dermatoscope for the margin estimation of melanoma. Let me show you some examples. Look at this patient. He has this very ill-defined lesion here on the ear. Again, you can see here is the lesion ending here, the lesion ending here. And look how we can use the UV mode for enhancing of the margins. Again, you can see here this rhomboidal pattern, some asymmetric follicles here, maybe annular granular. This was alentaigo maligna, right? Solitary lesion on the earlobe. But look what happens when you turn on the UV mode. Look at the margins. You can see here, remember what I told you, that the melanin absorbs all the UV light, so you won't have anything bouncing back to your eyes. And you can see here how the margin is much easier now to delineate under UV mode, right? And this area here, which was subtle, was part of the main lesion. And this is how we use a 5 mm margin around our UV estimation, right? So we start the main tumor, we consider the main tumor, what is dark under the UV mode. Look at this patient, very tough lesion, right? It's a recurrent lentigo maligna. Look at this. That's the scar. And you can see here how you have pigmentation around the scar. On dermoscopy, it's mostly a homogeneous pattern, but here you still see some asymmetric follicular openings, classic of lentigo maligna. Look how UV can help here. It can really enhance your margin delineation. And this is how we can better plan that this is the main tumor. And around this, you need to add a 5 mm margin. So you can use this for a discussion with the patient. Is the patient willing to undergo this huge surgery, or maybe we're going to try MIGWI mode? What do you think, Nisa, here? Why would you do this in Turkey? Would you do surgery? Or you use...
Actually, I just delineate the borders and refer the patient to the surgeon. We don't have most surgery in my department, but I just delineate the borders with UV dermatoscopy and some other devices. And it's very useful, especially for the lateral margins.
Right, I agree with you, yeah. Again, I can't survive for margin delineation without UV mode anymore. But look at this patient. I'm going to show you something I think is useful with the UV. This is a huge melanoma on chronic damaged skin, right? Look at this. It's biopsy proven. That's the first biopsy of the patient. You're going to see dermoscopy, but we can also use this as a Woods lamp, as a traditional Woods lamp. So you don't need to use dermoscopy mode. If you turn off the lights of the room, or you can use a room without windows, we have the laser room without windows. So we put the patient in there, and we just turn on the Woods mode, and we're not using here as a dermatoscope. We're using this as a traditional Woods lamp for margin delineation. Look at that. And it's so useful. Do you use it this way, Nisa, too?
Yeah, exactly. This way.
So I think it's two devices in one, right? It's a traditional Woods lamp and a dermoscopy UV mode, right?
Yeah,
So
just like that.
I'm never using my big UV lamp, Woods lamp again, right? I'm only using it for vitiligo, for anything. And on dermoscopy here, you can see these angulated lines here, some granularity. This was again melanoma on damaged skin, and with UV, you can see here how the margins are easily delineated. I'm gonna skip this because Nisa is gonna show you about reflectance mode. But again, more cases, again, lentigo maligna, classic lentigo maligna, and you can see how I use these for margin estimation. It was a very ill-defined lesion, but with UV, so easy to understand where the margins are, when the lesion starts and ends. This was a defect after our surgery with control margins. Everything was negative with the first stage. There's something super interesting, Nisa. We're comparing our cases before UV mode, and we are now getting everything clear at the first stage. Back in the day, we had like so many stages to clear lentigo maligna, and now I think stage excision is like one stage over because we're using this. And again, of course, a functional repair. That was the lesion. Another patient with a similar lesion, but in this case, again, you see here the asymmetric follicular openings, maybe some rhomboidal structures. But you can see here, we were thinking this lesion was part of the main tumor, but you can see here that it was not. It was not connected to a tumor. So I think this was just a lentigo. We did a biopsy here before the surgery, and it confirmed it was not part of the tumor. And again, so we excised the lesion, and it was clear with one stage after UV delineation. Nisa, anything you want to say here, or you have more examples of these?
Just going perfect. Just going perfect. Great examples.
Great. Seborrheic keratosis, super simple. I think this is only one message here. Look at this patient. He has history of stage 2B melanoma. New lesion noted. He was very worried about this lesion. Again, let's be honest. With polarized dermoscopy, this was easy too, right? I'm being fair here. But with UV, the keratin is super fluorescent. So remember, melanin was dark. Keratin is super fluorescent. Look at this. Boom. 1 second. Comedon-like openings are so beautiful with UV mode. It's 1 second. And this was an easy example. But look at this case. This was a 63-year-old male. He's immunosuppressed. I have excised, I think, 12 pigmented BCCs, some SCCs. And on my clinical features here, I thought it was a pigmented BCC. I'm going to be honest. New lesion. Has this pearly, shiny surface. And on dermoscopy, I thought this might be some leaf-like structures. I mean, I was not sure, let's be honest with you. It was a pigmented BCC, seborrheic keratosis. And I was going to do a biopsy, but then I turned the UV mode. Look at this, boom. What do you think, Nisa? Very nice.
Seborrheic keratosis for sure. Very nice.
Beautiful, right? It's very nice, and I think very easy with UV mode. And
Yeah.
again, similar example, patient with melanoma, annulation on the back, and she was worried about, I'm being honest here, I knew it was septic, but look at this, boom. 1 second, computer-like openings are so beautifully seen with UV.
Beautiful.
What about BCC and May globules? Again, May globules, remember, are these white structures, white globules aggregated, and they tend to be calcifications on BCC and other tumors, not only BCC, but tumors that have calcification. And you can see here under UV, the calcium structures have this classic fluorescence, right? So we published this a couple of months ago, last August, where you can see here how UV can enhance the visualization of May globules. And you might think, okay, not so useful, but I'm going to show you some cases. Look at this patient. I was not sure if this patient had May globules, but look at under UV, boom, everything was a May globule. This was a micronodular BCC with tons of calcifications. Look at this. This is the first most slide. You can see the micronodular BCC here, and you can see, look at so many calcifications in between the tumor, which explain these May globules. This is the most surgery you can see here. Again, one stage thanks to the UV. This case I showed you, that's a calcification around the VCC. But look at this patient. I think this is a very cool example of the usefulness of the UV mode for BCC. So first lesion is here. This is a micronodular BCC, biopsy proven. We're gonna do most in this patient. So you have May globules here, right? Easy. That was my delineation of the patient. That was gonna be my first stage. But then I said, okay, May globules, easy. What happens if I turn on my UV mode? And look at this. What happened here? The patient had May globules outside of the field that I was not seeing with the polarized mode, right? This is a seborrheic keratosis. No, don't worry about that. So this patient, I changed my margin and then added this lower area here thanks to those May globules that were seen only with UV mode. So this was a new included area. And even though we did that, we found positive margins at the 6 o'clock margin where you saw the May globules, and you can see here the calcification inside the tumor nest on the most layer. So again, we knew there was some subclinical extension toward that area, and we had to we needed 2 stages to clear this patient. But again, that lower tail was seen only with the UV mode. So again, my bottom line is that you can see better the May globules with the UV mode. And again, I'm telling you, do a lot of surgery. So to me, another very useful tool is the UV mode before most surgery or any surgery, where you can see the surgical site, okay? So the correct identification of the surgical site is very important because wrong site surgery is the most common error in dermatologic surgery. And of course, there are many challenges. I'm gonna skip this, but again, many scars, sand damage. You're gonna see some examples, right? Look at this patient. She has a biopsy-proven BCC, and the patient presents to me for most, and I ask the patient, where's the lesion? I can't see the lesion, right? Where am I gonna do a surgery? And the patient is like, I have no idea where's the lesion, right? And in the end, I found like the biopsy report, it said nasal ala. But now, where's the site, right? Is this here? Is this here? Am I confident enough? Would I start the surgery, right? Maybe this, right? I had no idea. So let's see what happens with UV. Look at this. So the healing side, of course, has this vascularization because of the scar, right? And the vascularization, the hypervascularization also give us these dark areas, right? So you can easily find the surgical side with the UV mode. And that was very, very reassuring to me to start my surgery. So look at this. It's a video. You can see here how you can turn on and off the UV mode. And you can easily see now that the surgical site was here, and you can start your surgery. And this is what we did. Another patient, multiple Mohs surgeries before. New surgery here. Where is the scar? I'm not sure. Is this one or this one? All scars won't have these dark areas because they're not hypervascularized. But look at this. That's the surgical side. And look at this. Boom. So easy with the UV mode. And also, it enhanced the margin delineation in this case. So this patient needed 3 stages to clear this micronodular BCC. And of course, we did this functional repair. Another patient, look at this. Where is the scar? I'm not sure. Look at this here. So easy when you have a recent scar with the UV mode. So we did this study again, a retrospective study, 20 cases, UV versus dermoscopy, patients without a very clear surgical site. And we found that surgical site recognition was easier 93% of the time with UV than polarized. And the confidence of the surgeon in a scale from 1 to 10, it was higher confidence for recognizing the site with the UV mode. So in summary of these dermoscopic structures I showed you, I think you have polarized dermoscopy, non-polarized, linear, but we want to focus on UV mode, right? So milia-like cysts are very seen with non-polarized, but they're not seen with UV. In contrast, the comedal-like openings that are open to the environment are better seen with UV and, of course, non-polarized. The keratin, wow, is the best seen structure with UV. Make globus, again, very easy with UV. The white circles of SCC, in my experience, they are sometimes better seen with UV FD, but we need more studies for this. Network, melanin, anything, dark, very easy. Blue-white veil, dark. And the vessels, most of the time, they're well-defined with the UV mode. Nisa, I think I'm going to stop here. Do we have enough time, right? So you can start with your cases. I have some inflammatory cases, but I think only if we have time, we can discuss those. What do you think?
Okay.
Any questions? Let me see if we have any questions.
Only hearts coming up. Applause.
Hearts to you too.
Christian, that's incredible. Seriously.
Yes.
I like the chart with the dermoscopic features that you have shown. That is impressive, in my opinion. Very well summarized, and exactly what people always ask us, actually, in many events when we meet friends and customers, and they would ask, what is the difference between the DL5 and the other dermoscopes, and what is the purpose of UV? What is the benefit? Actually, we would probably need the chart that Christian demonstrated in a kind of a printed way, because that's perfectly summarized.
Yeah, and this helped
Send it to
before
you guys.
surgery. This is amazing what you showed to determine the margins of a surgery with such a useful device for that.
True.
Wonderful.
True.
Great. I think there are some questions in the Q&A sections. Have you seen them?
I'm looking at them now. So someone asked, Arshinias,
there was a question about topical imiquimod.
Yes.
Christian.
So again, Darshini, that's a great question. That patient we discussed in our tumor board. So most of these recurrent lentigo malignas, we'll discuss them all on our tumor board, because there's always this concern about having some invasive disease that you're not seeing on your biopsies, on confocal microscopy or with dermoscopy. That patient, we did scouting biopsies. We didn't find any invasive disease. So we asked the patient what the patient wanted, and the patient in this case decided for surgery. But yes, we were considering imiquimod. And regarding that question, yes, I treat a lot of lentigo malignas with imiquimod when they are like non-recurrent on the face. They are in situ. I can evaluate them all with my dermatoscope. I, of course, biopsy the most worrisome areas for invasion. So yes, I will treat this patient with imiquimod if the patient wanted, but I discuss those cases with my patients.
Very good. Very good. Very good. People, I would say, again, to remind you all, we have got a super promotion ongoing on the DermLite and FotoFinder web shop. Based on where you live, you could just log in and get that super promotion. There is a code that I think will be
Magic 10 is the code. But
is it called
wait,
Magic 10?
you will see the QR code, and then you can go directly to the shop.
To the Magic 10. That's very good. But again, I mean, Nisa, you have had probably your first DermLite I mean, nobody will believe actually your age because you have got definitely a good bet with the time. You just simply don't age. But what I know, I have seen one picture with you, I think with the DL1 from 2000 and I think it was 2005 or 6. Correct me if I'm wrong.
No, probably, but my first DL10 was from 2002.
My God. My God.
Yeah,
And
and
Nisa,
I was a second year resident in my
Wow.
department, and yeah, it was a lottery, and I got it because it was so expensive for me. I was a resident, I couldn't buy it, and I was so happy after that meeting when I get it, and I like my dermatoscope so much.
so that means 23 years, and in 23 years, you literally had every generation of DermLite that we produced in your hand. Give us your honest opinion already in comparison, the DL5 with the rest. How do you see that actually?
Actually, DL5 is not comparable with the other ones. I think it's the best version. Really, it's a very good dermatoscope. I love it, especially with the UV mode and the screen is big. Just the disadvantages for the intertriginous areas, for example, the eye, because the screen is so large, but the quality is very good. I love it.
But I'm sure you have another demoscope. Which one is the other demoscope you have, Farah? Which one is the second one you use?
Uh,
I
Do you
mean,
want me to?
no, the second DermLite, because I saw you also with the DL2, I think you had in your hand in the hospital.
I have all DermLite dermatoscopes. Hey,
Okay.
all of them. I have all of them. DL4,
You
DL3.
collect them.
Yeah, I collect them.
But no, the reason I question is
DermLite Photo Pro,
no, the
which is
Photo Pro is
captured my
incredible for.
camera. Yeah, it's the best, I think, for
But
especially good quality images. It's really good.
I think from ergonomic point of view, the art of DermLite has been always to design a dermoscope that really fits into your hand. And I have not yet really managed to convince Emilios Lalas and Geppi Argenziano to move from DL200 hybrid. They have been with DL2 hybrid, I think, since 20 years. They are just still with DL2 hybrid. And Geppi has got it attached to his body somehow.
Yeah.
So it's just kind of
truly variable. Eh?
Yeah. I mean, the DL200 is just a marvelous. It will never age. It's just like a Chanel bag. So it will always be there and look stylish and great.
And you, Christian, what's your opinion about the DL5?
Well, what can I tell you? I love my DL5. So I only use DermLite. So I sorry about I can't compare with other brands, but like I had DL1, DL2, DL3, DL4, and DL5. So I have been through everything. So I would say that before this, my favorite was DL3. Nobody believed me, but like I never liked the others. It was DL3 my favorite. I love DL3. The way it was made, but now I only use DL5. So when it took me a while to like change my eye and my adjust everything to the new colors of the DL5, but now I only use my DL5, and there are many reasons. First, the battery is like lasts forever, and that's a huge difference. Like DL4 battery, for example, when I was seeing lots of patients, I think 1 day, 2 days max. With DL5, it's my whole week, so I only charge it during Sunday's night, and then I grab it back. So to me, that matters. I mean, somebody would say I don't care about that, but to me, it's very important, the battery length. And then
good point. Very good point.
yeah, I think all the light modes it had, like again, I'm telling you, I would say 50% of my time is most surgery. So these light modes to me were game changing, and like I can now do surgery without them. Every single patient that I do surgery, I take a photo with polarized, with UV. I delineate the margins under UV. So again, for surgery, I think it's very, very useful. And for my diagnostic point, I show you some cases where it really changed my diagnosis. And Nisa is going to show some cases, but if we have time, I can show you a study we did with Nisa on some inflammatory lesions where I think it's also very, very useful. So,
and before the DL5, before UV, how did you determine the margins for?
just with polarized, just with polarized. Yeah.
Yeah.
Sometimes I use the wood lamp we had, but again, think about this, it's a huge department. We have, I don't know, like 20 offices. We had to knock the door. Who has the wood lamp? So I moved the patient to the dark room examination area, use my wood lamp for the lentigo maligna. Sometimes we didn't have time. So, but now it's on your pocket. Everything that's in your pocket, it works, right? It's
Yeah.
like some places that they share a dermatoscope. You won't use it, right? You need to have it in your pocket. I think that's the key for success. You're busy, you're running behind time with patients. If it is not in your pocket, you use it once every year, right?
It has to be yours, dermatologist's best friend. Yeah.
People, Nisa is already giving us a teaser of her
Yes.
presentation. Nisa, we see the slide, is UV dermoscopy safe for the patients? Is that your first slide?
Because yeah, I get a lot of questions about this. Is it safe for the patient? Is it safe for the physician? And here are the answers of these questions. Yes,
Good.
when it is used correctly and briefly, it's completely safe for the patient because the radiation exposure is actually similar with the nail UV lamps, which is 11 watts, but a nail lamp exposure limits around 10 minutes per hand. And in our procedure for per lesion, it's just less than 30 seconds. And this is medically negligible exposure. The precautions should be, we should ask patients to close the eyes or wear goggles, especially for children, not for the adult patients, because of risk of looking directly at the lamps, to the and how about the physician safety? Actually, it's very safe for the physician because there's not a chronic exposure risk here, especially with the sub-UVA and blue light may contribute to cataracts or retinal issues, but this is really, again, negligible. And maybe if you are so concerned about these things, you can use some protective measures like polycarbonate UV protective glasses, and you can avoid professional glasses without side shields because UV may reflect to your eyes. And these protective glasses versus color accuracy, blocking glasses affect color perception. So this is not ideal during dermatoscopic evaluation. And the alternative approaches using smartphone or digital screen as a visual intermediary in cases like this. So are you okay for the questions, Cristian? Do you want to add something more with these precautions and the dangers for the physicians and the patients?
I agree 100% with you, and I love that you show this. I mean, this is so important because we're gonna start hearing these like every now and then. Patients ask, colleagues ask, right?
Yeah. And Christian's cases were great, and I'm going to just show my cases. As Christian told us that we cannot see miliary-like cysts, white clots in UV dermatoscopy, but instead commoner-like openings as keratin, and these are blue structures over the surface, and they are really very helpful. And let's have a look at how they look like. It's a clear-cut seborrheic keratosis with these keratin cysts. And in sub-UV mode, we can see miliary-like cysts as white clots and commoner-like openings as black structures because we observe keratin as black structures, white as white, and melanin as black, and blood as black again in the sub-UV mode. And here are some comparisons of sub-UV mode and UV dermatoscopy. The first image is with polarized dermatoscopy, non-polarized, sorry, because we can see miliary-like cysts very clearly here. And in the sub-UV mode, you can see commoner-like openings as black structures and miliary-like cysts at the bottom of the lesion, like pores, they are here. You can see them. And with our UV dermatoscopy, the keratin cysts are very clear. Again, the comparisons, the keratin cysts as blue-white structures. And here there's a case. And what do you think it is, Cristian? The first one is polarized. The second one is non-polarized mode. And
Can you
this
show me?
was the
Yeah. So again, very hard lesion. I would say I'm not
This is a
completely
skin
sure.
of color patient,
Yes,
pigmented seborrheic
exactly.
keratosis
¿Qué quieres
versus
decir?
lentigo
Cuéntame la
maligna versus
Yes.
pigmented actinic keratosis. Do you want to say it with the UV mode or sub-UV mode?
Both. I would like both.
And this
Ooh.
is the sub-UV mode, and this is the UV mode. So what's your opinion now? Is
I
it
would say
easy?
easy, so much easier, right?
Easy. So much easy because we have a lot of keratin cysts here. This was a seborrheic keratosis, which was much more easier with the UV mode. And what do you think about this?
Again, I would be concerned about this lesion. My first one would be lentigo maligna. That would be my
Yeah.
difference.
Yeah,
I
because we
hope.
have angulated lines. So it's a chaotic lesion. And here are the modes, UV mode and sub-UV mode. With these modes, as you show, we can see the borders very clearly, right?
Yes, I agree.
So let's see the borders for both
And there's
modes.
no keratin,
Yeah.
so
Yeah, there's no keratin, and we have a chaotic lesion with angulated lines, and the borders are not so regular. They're not scalloped, so these lesions were excised, and histopathology was lentigo maligna here. But as you show, the borders, the margins are very clear with these modes. Again, this is a case of what? Is the solar lentigo?
no.
Let's look at the clues. I think we have some brown circles, but the borders again does not fit with solar lentigo, and we have some angulated lines. Some of them are looking like rhomboidal structures. So we need to take a biopsy here because this is not a clear-cut solar lentigo. But with the sub-UV mode, again, we can see the borders very clearly here. And this is the UV dermatoscopy. Again, you can see the pigmentation very clearly. And histopathology was here again, lentigo maligna. And these modes really very helpful with delineation of the borders. This is a
It was very
clear-cut
dark, the patient,
lentigo
right,
maligna.
Nisa?
Yeah, this is a skin of color patient and very dark lentigo maligna with a lot of clues. Actually, you can see how the borders are very sharply delineated here, and there's nothing around the lesion. So maybe here 5 mm margin rule is not necessary. Don't you think so, Cristian? Because this is a clear-cut lentigo maligna, and we can see the borders very, very clearly. So maybe in cases like this, 2-3 mm margins can also be enough because of because of the help of this sub-UV and UV dermatoscopy. There's nothing, no pigmentation around. Again, this is a lentigo maligna. There was a biopsy here, punch biopsy was performed, and the patient came with the biopsy result. So I knew the diagnosis, and the dermatoscopy is clear-cut lentigo maligna. And again, here's the comparison of sub-UV and UV modes. The pigmentation is very clear again. And again, we can delineate the margins, and they're all lesion-free after these excision borders. Again, you can see a very beautiful lentigo maligna with a lot of clues again. And with the modes, again, margins are so clear. There's nothing, no pigmentation around the normal skin. And this is also a sub-UV mode, and UV dermatoscopy is very helpful in the acral lesions, in the dermatoscopy of acral lesions. For example, we can easily say that this is a benign pattern, isn't it? Don't you think so, Cristian?
Yes, I
This is a
agree.
parallel furrow pattern. But the eccrine glands openings are not so visible, right?
They are not. I
So
can see
let's
them.
have a look at with the UV dermatoscopy. Now, the eccrine glands are much more visible with the UV mode. And we now very sure about that. This is an acral nevus. Actually, the patient was 4 years old, and this was a congenital nevus. But with the help of the mode, we can see the openings of the eccrine glands. Again, a lesion on the sole, and here you can see the openings very beautifully, and the pigmentation on the furrows, again, it's a very clear, and this was a compound nevus.
Wow.
And this is the sub-UV mode. Again, the eccrine glands are very visible with these modes. This is a very interesting case because the patient is 75 years old and he has Parkinson's disease, and he was treated with the L-DOPA inhibitors, and here is the dermatoscopy. Actually, we have here parallel furrow pattern, but it's a chaotic lesion, and this is a new onset lesion. It occurred 2 years ago, so we have to excise this lesion, even though we have a parallel furrow pattern here. This is the sub-UV mode, and this is the UV mode. Histopathology was melanoma in situ here. Again, like lentigo maligna of the face, the borders are very visible again with these two modes. This is, I saw this patient 2 months ago. This was a melanoma in situ again. We have pigmentation lacking skin creases, some black dots, and it's a chaotic lesion, but a very small one. And here's the comparison of different modes, sub-UV mode and UV mode. Again, you can see all the pigmentation exceeding around. For example, if you look at the periphery, you can see some pigmentation on the normal skin, and we excise the lesion according to these borders again. And this is another acral melanoma. What I am going to show you is with the UV mode, for example, let's go back to the traditional dermatoscopies. There is no eccrine glands opening, and they are visible with the UV mode. Can you see that, Cristian?
Yes, I can.
And now I'm going to ask you a question. This patient was very worried about this lesion. And when I asked the history, he said that this is just for about 2 or 3 weeks. And when I look at that, it cannot be a melanoma. And could it be a blood or hemorrhage? And let's have a look at with the dermatoscopes. And I will show you the classic polarized dermatoscope at the end of UV and sub-UV modes. What do you think about it? Does it helpful to you?
I think I can see the reach here highlighted.
Yeah. Okay, you like it?
I like it.
Okay. And this is the sub-UV mode, heavily pigmentation. So as I told at the beginning of my presentation, blood is black, melanin is black in the sub-UV mode, so it's not very helpful to differentiate blood and melanin with the sub-UV mode. And this is the polarized dermatoscopy. What do you think it is? Is it a melanoma?
No,
Hemorrhage. Because sometimes we need to see the color. Color is sometimes very important. And you can see that this is a claret red and this is a hemorrhage. And let's have a look at what happens after some curettage. It's all gone.
Beautiful.
And it's also useful in the nail. Again, you can delineate the borders. For example, lentigo, I'm sorry, I didn't take the photos, but next time I will show you nail unit lentigo. And when it is due to melanocytic activation, the color is generally very light. But when it is related to melanin pigmentation, the color is really dark brown or black. So it's really helpful for us to perform UV dermatoscopy for also nail dermatoscopy. For example, this is a child, so this is a nail matrix nevus. And here is the sub-UV mode. You see how black it is. And now this patient is 25 years old. What would you do? Do you think that this is a melanocytic lesion or non-melanocytic lesion? Would you like to follow the patient up, or would you like to take a biopsy in this patient? Cristian, what do you think it is?
I think it's a concerning lesion if this is an acquired lesion in an adult.
Patient
with
is 25 years old, and
yeah.
the lesion has a history of 1 year, and she said that it's growing. Patient is young, but do you think, would you like to take a biopsy or follow it up? I think it's
Also,
both can be done
both.
because we know that nail matrix melanoma is slow, and we can follow the patient up, and we can see if it is growing, then take a biopsy. But here in this patient, we have micro Hutchinson sign. You see the periangle pigmentation, which wasn't obvious in the macro images, but in the dermatoscopic images, this pigmentation was worrisome to me, and the distance between the bands are not so regular. And the patients also say that it's growing. And during with the sub-UV mode and UV dermatoscopy, I can see the coloration, and I can understand that this is a melanocytic lesion which is growing. I take a biopsy, and this was a melanoma in situ. And as Cristian shows us very beautiful examples of May globus, which is an indicator of high-risk basal cell carcinoma, which I agree, Cristian, a lot, because when I see multiple May globus, this is generally micronodular or infiltrative basal cell carcinoma. And also I observe this in trichoblastoma and trichoepithelioma. We know that these benign tumors really likes to it's very common to see calcifications in the tumor islands, at the periphery of the tumor islands, in trichoblastoma and trichoepithelioma. So sometimes it's really very hard to differentiate these two entities. And this lesion was excised, and histopathology here was trichoblastoma with May globus. And let's see with UV dermatoscopy, if this was, for example, seborrheic keratosis, we shouldn't see these white clots because white structures are not visible with UV dermatoscopy. Since we see these white structures, we understand that these are calcifications, and this lesion could be either a basal cell carcinoma of high-risk type or trichoblastoma or trichoepithelioma. And this is a sub-UV mode. Again, these calcifications are very visible. And this is a case of micronodular basal cell carcinoma with beautiful May globus. And there, when we look at this case, it seems that there is nothing, but there was something pinkish, and around the lesion, we observe a lot of May globus. And this is a non-polarized mode. And with the UV mode, they're very beautifully observed. And in the sub-UV mode, this time, it's not as visible as UV dermatoscopy. This time, vessels are much more better. But this was a micronodular basal cell carcinoma, which is not visible by the naked eye. And this is a young patient, and the patient said that the lesion has a history of more than 10 years. So we understand that this should be a trichoblastoma or trichoepithelioma because of the young age of the patient. And we have a lot of May globus, and histopathology showed that this is a trichoblastoma with May globus. Again, another trichoblastoma with a lot of May globus. And this is UV dermatoscopy, and this is a sub-UV mode. And now I have a question, and this is a very challenging case. The lesion is on the back of the patient. It's a pink lesion. It was a little bit elevated, not a very flat one, but this is a lesion. And clinically, I think that this is a basal cell carcinoma. And dermatoscopy, we see serpentine and some branched vessels with May globus. This is polarized mode. This is non-polarized mode. Again, we see these white structures. And this is UV mode. Again, we see these white structures. And this is a sub-UV mode. And the vessels are much more visible with the sub-UV mode. And we have a lot of calcifications. So we excise this lesion with the preliminary diagnosis of micronodular basal cell carcinoma and trichoblastoma. So which is your preferential here? I think this is very impossible to know the diagnosis here, because when histopathology came, I was really very surprised. And this was a poroma, and we published this case last month. So which was very surprising to us, and we need to ask the case to different dermatopathologists, and they all confirm that this is a superficial poroma. And now I can stop here and talk implemoscopy later after you, Cristian. What do you think?
Yes, I think it's great.
Yeah, okay. So you first continue, and I will talk.
So there's one question here. What medium are you using for the dermatoscope? Ah, that's a great question, Jessica Dorsey. So they're asking what medium, what fluid. I use
Yeah.
50% alcohol. I fill my bottle. I have a small bottle like this spray bottle with 70% alcohol, and I spray over the patient a couple of times, and then I put my scope. When I use the reflectance mode, though, I learned the hard way that the best fluid for that is the ultrasound gel for the UV reflectance mode for the other one. I don't know what you use.
Same. Completely same way. Sometimes water as well.
There are some questions here. Oh, the same. What medium are you using? Oh, Nisa, maybe you can answer this question. How do you get the sub UV photos and the UV photos? If you want to answer that question to Rebecca.
I have different devices, so I have a lot of cameras, and that takes a lot of time to collect all these cases. So it's with a different camera, sub UV mode.
Yeah, so DL5 only has UV-FD, like the fluorescence mode, the blue one. The black and white is another camera.
Yeah, another camera. The other one is DL5.
Jean Kanitakis is asking, media like this contain keratin, which is supposed to be bright on the UV-FD. So Jean, I don't have a clear answer. I think only because keratin is not exposed to the environment, the reaction is not happening. I mean, it's just a hypothesis. I haven't done like a real physical study. I can tell you that when keratin is exposed to the air, like in an AK, SCC, or comedonal like openings, you can see it bright, but I can't see it on the media light. I don't know if you know the reason, Nisa.
Actually, that's correct, because I read from the literature that that's all due to the keratin. So it's absorbs all the light, and that's why we just see the keratin component.
Yeah. Then Ila Sanur is asking, do you use the pigment boost mode? I don't use the pigment boost mode. I don't even know if it's on or off. That's the real answer to me. Nisa, do you use the pigment boost?
No, never.
Yeah. Maybe it's on. I don't know. Yeah. Sorry.
No, the device has got many features, and in comparison, and we know that among you dermoscopists, there are different levels. There are the ones that have they are very demanding when it comes to different features of the dermoscope. Others who are always going with the same options. And let us maybe see if we can get in the one man who actually designed the DL5 and came up with the idea to add a pigment boost in it. Torsten, can you tell us?
Welcome.
Torsten.
Hey guys.
You
Hey
missed
Nisa.
a
Hey
great
Cristian.
Hi,
lecture.
Torsten. Good to see
Hey
you.
Mo and Katrin. Yeah, I missed it. Sorry, my travel schedule wouldn't allow for it. But I think I missed something extremely exciting, it sounds like. And I was just browsing to the participants, and I feel like I have to say kisses and hi and hugs and everything to all those attendees. I see Manuela here, Rasul, I see Gabriela, I see Pile, I see many other Murad, Michel, so many friends. So I'm so excited for you all to be here and make the time to join Nisa and Cristian and Katrin and Mo
Torsten,
and myself.
answer the question. Don't tell
What
us
was the question?
Answer the question. Why did you create this pigment boost in the pigment booster? What is that for?
Okay, so there's we have one of the founders of 3Gen is a physicist, right? He has a experience in imaging, and he believes in multispectral imaging and the advantages of using wavelengths to show you and highlight certain structures of the skin. And that wavelength is supposed to highlight and induce or increase the contrast of pigmentation, that particular wavelength that we call pigment boost. Okay, so that's the theory. Clinically, I leave the rest up to you. I'm not a doctor. So, yeah. Does that answer the question without giving you an answer? I feel like I gave a politician answer.
Yeah, you did.
There are lots of questions today. I think we never had so many questions in an academy.
And Cristian is really real. You are super productive by answering the questions. Meanwhile, Nisa was giving a talk. You were kind
I
of
was trying to, right?
excellent, excellent.
Okay, now we're gonna move to another area of like UV mode. So again, I work in a melanoma unit, but every now and then I see patients with non-oncologic diseases, right? So I'm gonna show you some cases where also UVFD is useful, and maybe it's even better for these cases. But I don't have a clinic for this, so maybe even the non-oncologic uses of UVFD are even better. But again, I'm gonna show you what I've seen. So again, patient with these nodules on the genitalia area. And of course, you were thinking about scabies. And you have the delta sign here. This is a magnified image. But when you see scabies mite with UVFD, not always, but most of the time, you get this green fluorescence. And I think this is important because when I see my residents deal with scabies patients, they always are confused about, is this a crust or a delta sign? Because the delta sign is smaller than you think when you see it live, right? All these photos are blown up. You have a zoom, digital zoom, whatever. So when you show delta sign on presentations, in reality, it's very small. And sometimes you get confused with crust of conservation scratching, right? So when you get this green fluorescence, is very characteristic of scabies. And we published this with our friend Pavel a while ago, that you can see scabies green, and you can increase your specificity. This is the real size, by the way. This is without zoom. So this is how you're gonna see it with your eye, right? But I don't know how our brain does this like digital zoom, and you can see it once very easily. And what about patients with skin of color? This was a patient of mine with history of acral melanoma who came here to my clinic with these papules here. I was not sure, could be harder because of the pigmentation. And again, here, again, you might think it was scabies, but this is with polarized mode and magnification. You see here the delta sign and the pigmented burrow. But look at this with the UV. Has this green fluorescence that is very characteristic of UV of scabies, and you can easily recognize the mite with UVFD, and you can differentiate from crust, which I think is a very useful use. And this has been published by this Turkish group. Nisa, do you know these? These are your friends?
Yeah, I know them very well. Yeah.
So look at this, bright green, and here also bright green, bright green. Look at this here, bright green, very hard case, but you can see the bright green here of the mite. Nisa, you want to add something about the scabies? I think it's very cool, right?
Yeah, the fantastic images. They're all great.
What about molluscum and warts, right? Two classic papules on children, on young adults, sometimes not easy to differentiate. Sometimes you're not even thinking on molluscum, and the UVFD can help you. So look at this, is a molluscum with polarized light, and the body of the molluscum, look at these molluscum bodies here, are bright under UVFD. Again, we are not sure what is shining here, but it seems there is a small connection to the epidermis of these molluscum bodies, right? Right here on the central portion of the area. So maybe that's what is giving this fluorescence, this white fluorescence. Another molluscum here, not easy on polarized mode, but look at this, how easily you can see the body of the molluscum with the UVFD. Warts, they are full of keratin, right? They are hyperkeratotic. You can see here the whole surface shining white with the UV mode. Look at this here and this here. More example of molluscum, I think this is the same. And we did this study, and we asked the participants to rate the confidence versus UVFD versus polarized. And look at the diagnostic confidence for both UV mode for molluscum and warts. They were more confident on doing the diagnosis. I think there were like 8 or 10 raters seeing these polarized and UV mode images from warts and molluscum. So you are more confident on doing diagnosis of molluscum warts with UVFD. And again, this is the same, like just showing you more numbers, and this doesn't matter. But look at this. This was a case of an adult on the lower eyelid. We thought it was BCC, but look at this. Boom. 1 second with UVFD. You can see here this central portion with the body of the molluscum. We still did a biopsy, and it was a molluscum. So you can see here how
They look
UVFD
like globules here.
I'm gonna tell you the difference in a while, but yes, they tend to be on the center in this case. I think, Nisa. I think that's the
Yeah.
key.
Yeah, that's the key point. You're right.
For porokeratosis, I think you're gonna show some cases, Nisa, too. But I think it's very cool. And this case to me was mind blowing. Again, patient with a BCC on the nose. I think I did a most on the patient, but she also mentioned me. Look at this, doctor. I had this for years. I had a biopsy on another institution. I came back prurigo nodularis. They have given me steroids for years. And I can help you. I don't do these very hard cases. I mean, I do skin cancer. But let's take a look with the scope, right? That I can help you. And with the
Wow.
scope, I think this one here,
Amazing. So beautiful.
you know what it is, Nisa. But give me 1 second. What about this now? Look at this lesion here. What about this now, Nisa? You know what
Yeah,
this
but
is.
again,
You know what this is. But look at this. What happens with UV? Easier, right? Much.
amazing.
You can see the keratin rim shining with fluorescence under UVFD. And you can also see these follicular
Follicular
plaques
plaques.
you have inside, right? Another lesion here. Look at this. Again, the patient was treated. That was the old biopsy. I think they didn't do it on the peripheral, right? They did it on the center of the lesion. That's why they never got diagnosis, right? And look at this. The
Wow,
rim.
that's amazing.
This is like the plaques. So I did an ink testing here. I used my pen here. This was before the UVFD. And then I wipe it out with an alcohol pad. And you can see here on the polarized slide how you can highlight the rim with the ink testing and the follicular plaques. So I said to the patient, I'm going to do a biopsy. Okay, I know it's not my topic, but I'm going to do a biopsy. And of course, it's alternating layers of hyperkeratosis, and this was a porokeratosis. So the patient, after years of steroids, never had prurigo nodularis. The patient had porokeratosis, and it was UVFD that gave me the clue for this patient. Again, another patient of mine, history, I think, of SCC. She came for the skin check. She said, doctor, I have this new lesion here. And I'm telling you, I was concerned about a skin cancer here. Solitary lesion, just a single lesion. But look at this. Oh, nice, right?
Beautiful.
I thought it was I was not sure with polarized. It was pigmented lesion. What is this? AK, whatever. But it's 1 second. You see the plaques and you see the keratin rim on the periphery. Again, this is another patient, not the same patient, just to show you how you can see the keratin rim with the UVFD mode. There are already some publications on this issue, but you can see how easily you can see the keratin rim without ink, without anything, with the UV mode. And we're doing this study, and Nisa, of course, is part of the study where we're comparing polarized light versus UVFD. And you can see here, these were 3 raters. The peripheral rim was seen in 66% of the polarized, but 95% of the UVFD. And follicular plaques is even more impressive. Only 24% of polarized light and 64% of the UVFD. And I think the kappas are very good. They all range from 0.1 to 0.7. So I think they are very good inter-observer agreement for these structures. Look at this patient with a solitary lesion. I was never thinking about porokeratosis, but now when you give this 1 second and you do your diagnosis of porokeratosis. So these are all my cases. This is a photo from my balcony, looking at the Andes there in Chile, in Santiago. This was last year. We're entering winter, so no snow yet, but this is how you see the Andes from my balcony. And I hope you like these cases of UVFD. And I know Nisa has more cases, but I'm open to it.
Great cases, great cases. Thank you, Cristian. I love your presentation so much.
Cristian, you have inspired already so many people also in the live events when you do your presentation in exhibitions and congresses. It's really great. Appreciate your enthusiasm and your passion for discovery, because that's what you stand for.
Exactly. And actually now it would be time for a pisco sour, right?
Yeah, that would be great.
I mean, I have some work to do, but maybe later.
We are already in the after work mode, right?
Yes. Oh, by the way, it's 10 a.m. here, so don't get me started. This is water.
That was the strongest drink I ever had when traveling.
To Chile, and we started to drink that with Raúl Cabrera at
Yes.
midday. So I think at 1 in the afternoon, I was telling Catherine, this is gonna be a very long day.
Yeah, it was
Starting
fun.
with Pisco Sour in Santiago de Chile at 1.
A good
For
idea.
lunch.
No, but people, it's definitely a place you have to visit. Chile is just amazing
Yeah,
as a country.
yeah, the view from your
Absolutely.
balcony, beautiful.
Nisa, you're next here, maybe, right?
Hopefully.
Thorsten, what do you say? Yeah, you have seen now some cases. Amazing, right?
I'm wondering to what level our audience is excited and inspired to learn more about UVFD and eager to learn about how to apply it in their clinical practice. So I think it's exciting. I think it's one of those things that to me it would motivate me as a clinician to just use it on every lesion, just to figure out what else is there, what else can I use it for, and that's what makes me excited. You know, as a designer, I worked many years ago I had a client in the toy industry, and Lego. I think many of you know the brand, and have probably spent too much money on your kids on Lego product, like myself. Anyway, and I learned that a Lego toy is a tool of exploration. It's of learning. It's all about growth, right? Kids learn, they grow, and I think a dermatoscope is nothing else. It's a tool to learn, to discover, to grow professionally.
Exactly.
And
We are learning.
so
We are learning
exactly.
with the patients. Yeah, exactly.
Yeah. And the beautiful side effect is that we are healing patients, hopefully. So yeah,
That's the
that's
But
what
it
I
would
think.
be nice to have a Lego dermatoscope, so the kids edition for the next generation, yeah.
In
Lego edition.
pediatric dermatology.
Lego edition. That will be fun. You build your own dermatoscope, right?
Probably good. Yes, probably a good business case, because they probably get stolen all the time by the kids in your office.
Excellent. Excellent, everybody. Excellent. So what's next? Do we have cases, Nisa?
Yes.
We have some cases, some interesting cases.
Very good.
And actually, this was a really very challenging case, and the patient has these eruptions on the legs, gluteal region, and scrotal and penis, and they were heavily pigmented, as you see. And clinically, here the differential diagnosis can be lichen planus or something else. What do you think about it clinically, Cristian, with this case, other than lichen planus?
Very hard.
Derriere, maybe.
I have no idea. That's what
No idea. Yeah, maybe derriere because it's heavily pigmented, but the
Okay.
location doesn't fit with derriere. Okay, so this is the gluteal area, and this is dermatoscopy. We have heavy pigmentation, some scaling. That's it.
That's it.
And here again, the dermatoscopy. And here, these are my differential diagnosis here. But before taking a biopsy, I would like to see the case with the UV mode. And now the UV mode. Let's go. You see the peripheral keratotic rims all around. For example, here. The different thing is the coloration. It was green because in the publications we know that this coloration is generally whitish brown, bluish. Again, all the lesions have a peripheral rim. So I add porokeratosis to my differentials as well. And you see the dermatoscopy again. And histopathology was consistent with porokeratosis. And this is the corneate lamella. We see the lesion and the horizontal axis, and histopathology in the vertical axis. That's why this is the parakeratotic rim, and we see the lesion in the superior part. That's why the keratotic rim is just like circles. And the genitogluteal porokeratosis has 3 different subtypes, and our case was typotropic porokeratosis, which generally involves the gluteal region, penis, and scrotal area. And this is a very rare type of porokeratosis. And also we have mevalonate kinase gene mutation in this patient, and treated the patient with topical lovastatin and cholesterol esters and acitretin, and now the patient is under therapy, and I will show the treatment response later in my presentations. And another case, which is a segmental involvement, you see, it was on the leg, starting from the gluteal area and going to the right leg's toe, and here you see the close-up. I think the differential diagnoses are very similar, maybe segmental lichen planus, segmental derriere. Don't you agree, Cristian, here with me?
I thought it was lichen planus to me. That will be my differential.
Yeah, segmental lichen planus, segmental derriere, they're all possible. And here's a polarized dermatoscopy. This time there's a cornate lamella here, maybe, huh? Keratotic rim, which is not very clear with basic dermatoscopy, polarized dermatoscopy. Again, we have keratotic rim around the lesion. Again, you see, but with UV dermatoscopy, it's much more prominent, isn't it?
Yes.
And this was a case of segmental porokeratosis, and which was easily diagnosed with, again, UV dermatoscopy. Now I'm going to show you something. The patient has androgenetic alopecia, and here is androgenetic alopecia. And what are those things? Any guess? These pink, orange structures. They were all around, all involving all the scalp. And I'm asking the question to our audience as well. What do you think there are, these orange dots involving all the follicular openings? Actually, there are Cutibacterium acnes, which is responsible for these structures. And they are generally located, these bacteria, in the seborrheic areas, and they produce coproporphyrin 3, and this is the major chromophore responsible for this UV-induced fluorescence. And there's a seborrheic keratosis as well here. The interesting is, although the patient has androgenetic alopecia, we know that this is not a cicatricial alopecia. These Cutibacterium acnes persist only in viable hair follicles. And because the sebaceous glands are preserved, and as the stem cells are located in the bulge region, in very close proximity to the follicular mouth of these glands, these bacteria colonize in that region. So when we see these orange or pink dots in the scalp or in an alopecic area, we know that this patient doesn't have cicatricial alopecia. We can use this in the differential diagnosis of cicatricial versus non-cicatricial alopecias. For example, in lichen planopilaris, we never observe these pink orange structures. This is a sign for active hair follicle, which is very useful, I think. And the presence of pink-red follicular fluorescence can be age-dependent and may not be seen in children before puberty, because we know that before puberty, in alopecia area, we never observe yellow clots, because the sebaceous glands are not very active before puberty, and we don't observe these structures. And Cutibacterium acnes doesn't colonize before puberty. So in patients with alopecia areata before puberty, again, we don't observe Cutibacterium acnes. And there is a very good publication from the Holland group. And here you can see the comparison of alopecia areata and androgenetic alopecia. We have these pink structures because they are both non-cicatricial alopecia and stem cells are still active. Again, in androgenetic alopecia, we have these orange structures or pink structures, pink dots, because of this Cutibacterium acnes. And here also in alopecia areata, we have whitish hair, which is very characteristic for vellus hairs. And also we have here some black dots, again, which are signs for alopecia areata. Again, I would like to give you some information which I didn't know previously before preparing this presentation. In especially patients with alopecia areata before puberty, we can observe double or triple white follicular dots, and which is visible with only UV mode. These structures again correspond to follicular ostia, which are not colonized with Cutibacterium acnes or Malaceccio furfur, because there is no sebaceous activation before puberty. So these white follicular dots are characteristic for alopecia areata before puberty. Here are some photos, UV photos with alopecia areata. You can see these triple or double white dots on the scalp. And green, here we have some green follicular fluorescence. They are also sometimes observed in androgenetic alopecia, but they are not observed in non-scarring alopecias. Never observed these structures in non-scar tissue alopecias, green follicular fluorescence as well. Now there are 3 cases, lichen planopilaris, frontal fibrosing alopecia, and alopecia areata. As you can easily see, there is no Cutibacterium acnes in the scar tissue alopecias. There is one interesting study published by the Rodriguez Barata. They observed 12 patients, and they showed that the presence of Cutibacterial orange-red dots in the follicular ostia was a predictor of hair regrowth or stabilization after 6 months of treatment with duosteroid, topical steroid, and minoxidil. No regrowth was observed in patients lacking this fluorescence. And the authors also suggested that Cutibacterium colonization was maintained exclusively within viable hair follicle units. Again, I previously didn't know this, but this is also a very interesting information. The patient has some erythematous plaques on the back. Some of them was follicular papules. And here's the dermatoscopy. We have some dotted vessels here. And there's scale. And the scales have a yellow color. And here's the dermatoscopy, UV dermatoscopy. We have some pink color over the surface of the scale. You see, the color is pinkish. So what's your diagnosis here? When we observe pink color over the surface of scale, which disease can this be? Cristian, do you have any idea? This is the macro, and there are some scales, and there's pinkish color over the surface. Because dermatoscopy is not so helpful here, but this coloration will help us in the diagnosis. Actually, these cases are all psoriasis. Very interesting information, because in psoriatic plaques, papules, and Goodhart lesions, even Goodhart lesions, inverse psoriasis, we have this red coloration, fluorescence over the surface of the scales, and we observe this never in lichen planus, pityriasis rosea, other erythematous squamous diseases. For example, this is a case of lichen planus, and you can see the Wickham stria, and there is nothing in the UV dermatoscopy, because active proliferating cells showed increased red fluorescence, and these structures can be seen in basal cell carcinoma, squamous cell carcinoma, and psoriasis, other than infectious reasons. And because we know that keratinocyte proliferation is increased in these diseases or tumors. And lead fluorescence never observed pityriasis rosea, PRP, lichen planus, and mycosis fungoides. And the pattern of fluorescent distribution in psoriasis is quite unique compared to other erythematous squamous diseases. And studies show that fluorescent positive psoriasis patients have severe PASI scoring. Significant positive correlation is observed between fluorescence intensity and PASI score, and lesion autofluorescence can be used as a tool to represent psoriasis progression and response to treatment. And it was observed that protoporphyrin 9 fluorescence is increased in the psoriatic plaques in these studies, which is a very interesting observation for me. And for example, we can use it in the differential diagnosis of the scalp lesions. For example, we can differentiate it from seborrheic keratosis and psoriasis vulgaris. As you can see, the first two photos belong to psoriasis because we have pink reflection here, fluorescence. But in the last two photos, it's just seborrheic keratosis, just scale. No red fluorescence is observed. Really, it's very helpful in the differentiation of scalp diseases. For example, let's have a look at this. There are some scales, and with UV dermatoscopy, there's no red color. So this is seborrheic keratosis. And let's have a look at this case. This time, we have red fluorescence. Red fluorescence. Then this is a case of psoriasis. We can easily say that, conclude that. Which is interesting is also in inverse psoriasis, we observe dotted vessels in the polarized dermatoscopy, but in the UV node, this time the erythema was not homogeneous or focal, just above these dotted vessels, as you can see. And if this was a case of erythrasma, we have to see scales with homogeneous red coloration. So when you see dotted vessels and dotted red fluorescence, this is a case of inverse psoriasis. For example, this is a case of squamous cell carcinoma. Let's have a look at the surface, and you can see this red fluorescence. And this is a case of erythrasma for sure. Let's have a look at how it looks like. We all know the UV dermatoscopic features, just red structureless areas. And this is a classic dermatoscopy. And this is a bovonate papillosis, not a genital wart, and with a high risk. And over the surface, we have some red coloration. In this patient, I am not sure. This is secondary to proliferation and protoporphyrin 9 production, or there's a corynebacterium infection here, but maybe this is an overlap, or the tumor itself produce protoporphyrin here, but we have here this red coloration. And it looks like a lava, isn't it? Volcano and lava. And here, again, this patient has bovonate papillosis with high-risk HPV, and we have red structureless areas, maybe again erythrasma overlap with bovonate papillosis, or just bovonate papillosis produce protoporphyrin here. And here's a classic dermatoscopy, and you see red fluorescence over the surface of the lesions. I don't show scabious examples because Cristian showed us some very beautiful cases. Let's expand. And any idea with these lesions? Is this a wart or something else? Actually, this is a UV dermatoscopy, and this is classic dermatoscopy, and this is UV dermatoscopy. Wart or molluscum? Which one is your preferential here? Actually, when we observe these bluish white structures, which are keratin, they are belong to molluscum spectrum, and this is not a wart. For example, you can see these bluish structures, and again, this is molluscum contagiosum. And here, this time, we have erythrasma in the background and trichomycosis axillaris as bluish round structures around the hair shaft. And this is classic dermatoscopy, yellow concretions along the hair shafts. And now, this lesion could be a nummular dermatitis or tinea corporis, which is your preferential here. Nummular dermatitis, or tinea corporis. Is there any helpful clue here? Actually, the color, because we have here green coloration in the UV dermatoscopy. Green fluorescence is classically associated with pteridine, which is produced by microsporium species. And this is a case of tinea corporis. And again, we have green coloration. Again, this is pteridine, and this is tinea corporis. This time, we don't observe pteridine, and we have just scales, and scales are around the lesion. Some form circles, and you can see the borders. This is a case of tinea corporis without pteridine. There is no green coloration here. Probably it can be due to trichophyton, rubrum, or something else. And now, any guess with these lesions? We have erythematous background, and we have papules and pustules. Here is the classic dermatoscopy, and we have a lot of demodex here. So this is a case of demodecosis. And what is interesting is we don't have any Phytobacterium acnes here, just demodex. And it also involves the eyelashes. And these are cases of malassezia furfur, tinea versicolor. This is classic dermatoscopy, but with UV dermatoscopy, it's very easy to diagnose. You can see the scales following the skin lines. Again, cases of tinea versicolor, and the scales are very characteristic. Again, scales following the skin creases. And I saw that somebody was asking about what's the dermatoscopy of warts. Actually, it's not very characteristic because here we just observe keratin. But if we have dotted vessels, which is a result of papillomatose, dilated blood vessels, Auspitz phenomenon, we can observe this as black dots. But I think clinical classic dermatoscopy is also very helpful in the diagnosis of warts. But in UV mode, these black dots are very prominent again. You can see dermatoscopy of warts. And I would like to thank my colleague Handan, because some of the inflammoscopy cases were coming from her archive, and we are working together. And thank you for listening us. I hope it was a beautiful presentation for all of you. I really enjoyed a lot while preparing this presentation. And if you have questions, please do not hesitate to ask.
Bravissima, Nisa. Bravissima. Thank you.
Actually, these were 4 lectures. Wonderful.
To cover all the different benefits and aspects of UV. Very, very nice people. I hope I'm receiving already messages through all the channels, social media, etc. People following us today from Colombia to Asia even. That's wonderful. Thank you so much for preparing this great talk.
It was the first talk online about this topic in our academy. So
absolutely, and not definitely the last.
Absolutely.
No, seriously, guys. I mean, these are the high magnification as well as UV. These are topics that are quite new for us. We see still a lot to be discovered. The high magnification session, we even did one in Italian language because there was such a request, and we know that eventually FotoFinder and DermLite have been driven by the ambition and inspiration over the years. We discovered together with you, and you guys give us feedback that you have seen something that could be useful for everybody worldwide. We invest in it. We invest and we develop, and that is the result of it. So more to come about UV, more to come about high magnification. I think, Cristian, you have got one in your office meanwhile, the high magnification. I'm really curious to see what you discover, because we can compare it with confocal. I think there is a lot in dermoscopy that is still to happen.
Absolutely.
And we will be there.
What
you
about
can count on it.
I'm actually speechless. I've seen some of these images, for the past, it's been 2.5 years, I think, since we launched DL5.
Yeah.
and images kept trickling in, right? Initially, Cristian, and then from Nisa, and I'm blown away. And I have to think, like, are we gonna, like, if we were in a different generation, we would publish like this beautiful coffee table book with all these, the art of UV fluorescence dermoscopy. It would be absolutely amazing, right? Like some of these things, like it looks like I'm in some sort of strange alien planet inside some cave. I mean, it's amazingly beautiful. And the negative part is there's always a drawback to something. I think it makes regular white light dermoscopy look a little boring. It's like, where are all the colors? It's beautiful. So I'm really impressed by all your cases. Incredible.
Thank you. Thank you for collecting those cases. Thank you for taking the time to take the picture. I know that within the course of the day, when you have got lots of pressure, lots of patience, taking the time to collect images, to record the images, sharing them with us, that is exactly the kind of motivation we need to continue the job we do. And in fact, Nisa, your image, the one image that we actually use in many exhibitions, and we print it on a large octalumina kind sort of panel. It's worldwide so popular. It's so attractive. People come and ask us, what is this? The kind of colors, as Thorsten said. I mean, this is looks like from a different universe.
It looks like scuba diving or snorkeling and being in a new dimension.
It's just beautiful.
I actually have a question, and maybe you guys answered it in your talk, but I feel like this is a question we get a lot. Sorry, 1 second. I have background noise. What device? Of course, you used the DL5 to take those pictures, but what smartphone or device did you take to capture the actual images? Maybe Nisa, go first.
Actually, I'm using iPhone with DL5, and for sub UV mode, another device from a Japanese company.
Okay. And you, Cristian?
Yeah, I'm a Samsung guy, so I take all my photos with different Samsungs. Currently, I'm using a Z Fold, the one that opens.
Yeah.
And I think photos are great, but my friends use iPhone and the photos are great too. So I think
Would you say it matters?
Nah, of course, every phone has this special color calibration, but I think it's like the brand thing. Like, the Samsung photos tend to be some way than the iPhone photos, but I mean, I think any smartphone nowadays, with the adapter comes with the device, I think is enough.
Yeah.
You could use a tablet, whatever, right? And someone was asking about the settings. I don't set anything. I just open the camera in the automatic mode and take the photo. Do you, Nisa?
Okay.
Do you go to manual mode and set the bright and everything?
Yeah, everything.
Yeah, I just use like the automatic, like just like open the phone, camera, and that's it. And do anything else.
It takes a lot of time because I have a lot of cameras. Because I capture with iPhone DL5, DermLite Photo 2 Pro, and another professional camera, and with the other thing. And sometimes one patient takes more than 20 minutes just for taking photos.
Okay. Okay, but we will solve that problem, people. We promise you. I mean, imagine in this company, we will never stop to develop. And of course, the applications that we are at the moment developing will guarantee you the best pictures that you can have. As we can calibrate, we can do this. We're doing a lot to save your time. And that is one of the reasons why
I'm waiting for that, Moha.
I know, Nisa, you're waiting for that. We take care of it. But the point you mentioned, that's a very valid point. One of the reasons why we develop apps is because we are able to calibrate in a way the camera that you get the best possible picture with your DermLite. That's coming, people. That's coming. We never stop to develop here. That's what we can promise.
Absolutely.
Okay. People, what a wonderful Friday afternoon, Friday morning in Santiago de Chile. Thank you very much for being with us again in a special DermLite UV edition.
Absolutely. It was a wonderful session. And maybe you have the last words. First Thorsten and then Nisa and Cristian.
I can only express my gratitude for your amazing, inspiring talks. So thank you for all the good work you and your teams have put in. Absolutely amazing. And I think I speak for everyone who participated in this event, everybody who took the time at home in their offices to join us here. I think I don't know. I'm still blown away, and I think many of our audience share that feeling. So thank you so much.
So do we, and maybe just one hint that we have also live academies this year in New York and in London. You find everything on our website, and also the next online session, which is on AI in May.
Oh, yes, yes. The Academy is 2 platforms, online and live.
Yes.
Online and downtown London, downtown Manhattan.
Yeah.
Nisa, thank you so much for your presentation.
Thank you. Thank you. It was a great pleasure. Always a great pleasure. And thank you for all audience for being together with us, and looking forward for the next events.
Thank you. And people, Nisa will be in a great congress also in Kazakhstan, in Astana, I think soon. Those who want to see her in life and in perfection, go to Astana, Asian friends, and you will meet her together with Raymond, and probably also the greatest wingman of all time, Mr. Thorsten, will be there too.
Yeah, come to Astana and let's
But before
party.
he goes to LA, right, Thorsten?
Yes, right now, LA, yes.
Cristian, thank you so much for being with us today.
No, thanks to you guys for inviting me. Sharing with Nisa the stage was fantastic. Nisa, I learned so much from your inflammatory cases. I told you, I'm sure there are more inflammatory applications than oncology. So to prove my point, thank you for the audience. Everyone was so nice, participating, asking questions. I love this. So thank you, and hope to see you live someday soon.
We will see you in live, everybody, and please enjoy your weekend. In Europe, at least, La Primavera, the spring is coming, everybody. Enjoy the wonderful weather. Turn off your mobile phones and have a lovely weekend, everybody.
All right. See you next time.
Thanks, everybody.
See you somewhere in the world. See you. Ciao.
Bye-bye.
Bye-bye. Bye-bye.